Hi, my name is Dr. Franco Cassio, and I'm the Chief of Pain Management and the Chair of the Pain Management Committee at Huntington Hospital. My goal in this section is to provide a brief overview of what pain is and offer some helpful tips on how to best optimize your patient's pain regimen. The definition of pain by the International Association for the Study of Pain is an unpleasant sensory or emotional experience associated with actual or potential tissue damage. The take-home message is that pain is more than just the sensory input, but also the emotional experience associated with the pain. Put more simply, pain equals not just the stimulus, but the interpretation and response to that stimulus. We wanted to provide a table discussing some of the differences between the different classes of opioids and the different potencies. In this table, the highest milligram dose is the least potent, and the lowest milligram, or in this case microgram dose, is the more potent. So fentanyl is the most potent medication here, being the 100 mics of fentanyl IV equals 10 milligrams of IV morphine. And you can also use it to compare IV and oral doses. So 10 milligrams of IV morphine is going to equal 20 milligrams of oral Percocet, or 7.5 milligrams of oral Dilaudid. Another thing to note on this is ketorolac down at the bottom at 30 milligrams IV is the equivalent of 10 milligrams of IV morphine. So don't discount Toradol as an effective pain strategy. Tips for effective pain management. Always evaluate patients for acute changes when escalating their pain management regimen. Look to see if they have a non-opioid standing medication ordered, and if not, ask their provider if it would be medically appropriate. You can offer alternative treatments to patients to better manage their emotional component to pain. Always ensure that the patient's opioid regimen matches their needs. Make sure that there's 2 PRNs available, and make sure that their doses are appropriate, and that they're actually getting relief when they receive their PRN. If their PRN doses are not lasting in between doses, maybe you can ask the provider to increase the frequency. If their doses are not effective, you can consider increasing the dose or request a PCA. If the patient's not utilizing all of their PRNs, it's a good time to do some investigation and determine why that might be. Are they aware that they have the PRNs? Is there tolerance issues? Is there a fear of addiction or dependence? And then it's a good time to educate them on some of the alternative treatments that are available. If patients are taking long-acting opioids at home, they should continue them unless medically contraindicated. Opioid therapy can cause respiratory suppression and hypotension, so always use caution when escalating. And most importantly, don't underestimate the benefit of alternative modalities such as relaxation, meditation, or aromatherapy. They may not reduce pain from severe to moderate, but they should be looked at as the standing non-opioid pain order. Acetaminophen will help modulate the incoming pain signal and limit the frequency of pain spikes in severe pain. The holistic modalities can be thought of as having the same effect, but instead for the emotional processing of the pain stimulus.
It is a Joint Commission requirement that all hospitals provide non-pharmacological modalities for pain management. These therapies can be used by themselves or in conjunction with current medication orders. What are these therapies? Ice, heat, aromatherapy, breathing exercises, massage, imagery, distraction, and laughter are just a few. Clinical aromatherapy is the use of essential oils for a specific purpose. Oils are distillants or concentrates from flowers, plants, and fruits. They are extremely powerful, about 100 times more powerful than the actual plants themselves, so a little bit goes a very long way. Inhaling an essential oil has the quickest onset. The molecules cross the blood-brain barrier and affect our limbic system, which is responsible for memories, emotions, and the fight or flight response. We can only use the essential oils that are provided by the hospital and for inhalation only. Most often you'll be using the pre-filled inhalers, but if you do choose the bottles, remember a little goes a long way. You only need a drop on a piece of gauze. but which ones to use. If we're hoping to help someone relax, sleep better, or help with their perceptions of pain, you may choose lavender, mandarin, or frankincense. If someone has an upset stomach, ginger or peppermint would be the choice. Peppermint is also very good for headaches. And if someone is a little tired, just needs to be uplifted, or having their day brightened, lemon is a good choice. Remember, you can find patient education sheets in chart forms on your desktop, which explain clinical aromatherapy, why you chose that oil, and it gives them a brief breathing exercise as well. Creating a relaxing environment is another non-pharm modality for pain management. You can do this by turning on channel 24, our relaxation channel, which is a continuous loop of nature scenes, music, and guided imagery. You can also select specific videos by using the remote. Hit the menu button, option 2 for patient education, and then press option 2 for relaxation videos. Our non-pharm modalities need to be charted in Sunrise. Go to Flow Sheets, Adult A&I. In the Coping Psychosocial section, add a parameter for Holistic Integrative Therapies. You'll chart the indication for therapy, the why, the non-pharm therapy that was provided, and your outcomes or response to treatment.
As nurses, we know that clinical documentation is important first and foremost because it's fundamental to safe, effective care. By following policy and procedure, you protect your nursing license. We all learned in nursing school, not documented, not done. Screening for pain takes place first in the ED on arrival and at the time of admission. Also at each visit in the ambulatory setting, and for all inpatients on admission and at least every 12-hour shift. Remember to chart the patient's acceptable level of pain at the time of admission as well. Assessments are done using an evidence-based assessment tool appropriate for the patient population. Samples will be provided. Once pain is assessed, it is classified for treatment on pain scales from 0 to 10, 0 meaning no pain, mild, pain level 1 to 3, moderate, pain level 4 to 6, severe, pain level 7 to 10. All interventions must match the orders for the corresponding pain level. Escalate any concerns with the provider if orders need to be changed, and remember to utilize your clinical pharmacist as a resource if you have any questions. Also consider combination therapies as a means of better control. So this is very important. Your interventions must match the corresponding pain level on the orders. Look at the example below where Tylenol 650 is ordered for mild pain, Tylenol 1000 is ordered for moderate pain, and Percocet is ordered for severe. With these orders, Percocet cannot be given for a pain score of 6 because the order is for a score of 7 to 10. Likewise, Tylenol 650 cannot be given for a pain score of 4 when the order is for Tylenol 1000. So here's where it's tricky. Your patients may refuse a certain order or they may request a certain order, but you need to stay within the parameters that are in the orders. Otherwise, you're practicing outside the scope of nursing practice. Remember, every time you work a shift, you need to assess for pain at least once during that shift, even if the patient is without pain. When giving a patient PO analgesia, policy requires that you reassess your patient 30 minutes to 1 hour after giving the med. For sub-Q and IM, reassessment is 30 minutes after administration, and for IV, it's 15 minutes. But keep in mind, you have 1 hour to document these reassessments in your flow sheet. Here are some examples of questions that may help you better understand your patient's pain. The third one is my personal favorite. Asking the patient, does the pain prevent you from taking a deep breath, from turning in bed, walking to the bathroom, getting enough sleep, getting in and out of bed or to the chair? This data table shows how often Huntington Hospital is documenting according to system policy. The data is pulled directly from Sunrise, and as you can see, we have a great deal of opportunity for improvement. Our 2022 goals for improving documentation are the education today, one-to-one chart reviews with RNs, sharing compliance rates at the unit level.